Alright, so in this video today, I'm going to be attempting to run through a various assortment of fractures in the upper extremity. So there is distal forearm fractures that can happen to the radius and ulna, and then I will be talking about scaphoid fractures, and lastly is the hamate fracture. So for all of these, I'm going to be going through the components of the examination and the important details that you would find during your exam. So I will begin with the history portion, which is very important for these injuries since there are not a lot of special tests to run in this scenario. So for the history portion, for a distal forearm fracture, you will want to ask them about the mechanism of injury, and for that it's going to be an acute incident, most likely from a fouche or falling on an outstretched hand, and that will apply axial load on the radius or ulna and could lead to a fracture in the distal head of those bones. And then you'll want to ask them about their pain characteristics. So for something like that, there's going to be immediate pain, and it's going to be a sharp type of pain. The pain level is going to be very high for this type of injury because there is going to be some displacement. So it's probably going to be around 8 or 9 on the pain scale. And I described that's going to be sharp and it's going to be constant. And then you'll want to ask if they have had any previous injuries to this arm before that may predispose them to something like that. If they've had maybe some previous sprains of the wrist or anything that have weakened the integrity of the joint. And then you'll want to ask them if they are able to perform any range of motion. Since the distal forearm is going to be an obvious deformity for the observation, we're going to want to check their capillary refill and their distal pulse to make sure that the neurovascular structures are still intact. So that covers the history portion. You'll want to get the MOI, which is falling on an outstretched hand. It's going to be an acute incident, and their pain level is going to be very high. It's going to be constant sharp pain, either localized to the radius or the ulna, the distal 1/3 near the head. And then for the scaphoid fracture for the history portion, this is also going to be an acute incident. Again, it could happen from a fouche mechanism, so falling on an outstretched hand. They could also have some direct blow to the scaphoid bone that could cause this type of injury, or the axial loading down the first metacarpal or the thumb joint could result in a scaphoid fracture as well. With this type of injury, they are going to have some immediate sharp pain, but then the pain will become diffuse as the injury prolongs in time. So you'll want to get that examination in right away so you can catch that immediate pain where it's localized to, because after a while it becomes the diffuse pain in the thenar eminence of the hand. And then with scaphoid fractures, you can also have avascular necrosis since the blood supply is not very good to this area. So with something of this nature, it could be something chronic as well if they have repetitive microtraumas to the scaphoid that can build up over time and cause a fracture. So that's the history portion for the scaphoid fracture. For the hamate fracture, the history portion is somewhat similar. So it's again usually an acute type of injury. It happens from the fouche falling on an outstretched hand, or they could have a direct blow to the hamate, or they could be holding some type of sport equipment like a racket stick, lacrosse stick, baseball bat. If they fall holding that, that could lead very easily to a hamate fracture. With this type of injury, the pain characteristics again are going to start out very sharp localized pain to the hamate region, but after a while, again, this pain becomes diffuse in the hypothenar eminence or around the pinky and the fourth finger in the hand. With this one, previous injury is not that important since this usually is something that is acute, so it's going to take that one incident that builds up and causes this pain. And then also another mechanism for the hamate fracture is axial loading of the fourth or fifth finger. If you have that going down the hand, it could lead to a fracture of the hamate body. And then they may also describe some neurological symptoms. The ulnar nerve runs through the hamate bone. So if you have a fracture to the hook of the hamate, it could disrupt the ulnar nerve and lead to some neurological symptoms in the fourth, fifth, and middle finger. So they could describe some numbness or tingling in their hand. For the observation section, so the next part of the HOPS is the O, observation. For the distal forearm fracture, again, I mentioned there's going to be some obvious deformity going on. And so in that case, it's going to be pretty evident if they have a fracture of the radius or ulna. The Colles fracture is when the radius displaces dorsally on the arm, so in relation to the hand it displaces upwards. And the Smith's fracture is when the radius displaces palmarly in relation to the hand. So those are the two types of distal forearm fractures. The scaphoid fracture for observation, you may notice some edema in the anatomical snuff box, so this region here on the thumb. But it's going to be very minor. You're not going to be able to see much during your observations for the scaphoid fracture. And the same can be said for the hamate fracture. The observation is going to be very minimal. You're not going to be able to see many telltale signs with your eyes, so that's why the history is very important for those injuries. Something they may describe to you as decreased grip strength with all three of these fractures, so that's something you're going to want to ask about for sure. Now I've done the history, observation, we're going to go into palpations. I'm going to run through the extensive list of the palpations, and then as I'm doing them, describe which ones would be 10 or 2 palpation for the specific fractures that I talked about. So you'll begin in this position. I'll palpate the shaft of the radius down to the distal head and radial styloid process. So you got that right here. And then you can do the same thing on the other side of the arm. You can palpate the ulnar shaft going down to the distal ulnar head and ulnar styloid process. For the forearm fracture, these areas may be 10 or 2 palpation, depending on which bone was fractured. So most commonly it's the radius, so the radial styloid process is going to be 10 or 2 palpation. And it's also going to be visibly displaced either dorsally or palmarly, so you'll be able to tell that that is an area of weakness. And then staying on this side, near the radius, you have Lister's tubercle. And then if you ask the patient to extend their fingers, you'll get the extensor tendons in the hand. And then with the thumb, if you ask them to abduct, so go out, you can get the anatomical snuff box to appear. So that is made up by the abductor pollicis longus and the extensor pollicis brevis on the most medial aspect. And then in this region you'll have the extensor pollicis longus, which makes up the borders of the anatomical snuff box. So we can also palpate in that area, and that's going to be where their 10 or 2 palpation for a scaphoid fracture is, in the anatomical snuff box. And then I think that covers about everything on this side, so we can flip them over. And then you'll want to palpate the pronator quadratus. Is a soft tissue structure that runs along the carpal tunnel area as well, so you can palpate those soft tissue structures. If you ask them to flex their hand, you'll get the palmaris radialis longus, radialis flexor longus, the palmaris longus, the extensor ulnaris longus tendons to pop out. And then you can also palpate into the hand. You'll have your carpal bones. So starting here, you have your scaphoid, your lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and then hamate. And you can palpate the hook of the hamate by digging in there. The soft tissue structures that overlie are the thenar eminence near the thumb. You have the thenar web space that lies between the first and second digit. You'll have the central compartment where some soft tissue runs in there. And then you'll have the hypothenar eminence, which is near the pinky. I think we've covered all the palpations. So for the scaphoid fracture, I mentioned that the anatomical snuff box is going to be turned to palpation. And that's about the only spot that we're going to be able to palpate that will give us a clue on where their injury is for that. The hamate fracture is again going to be localized pain, so it's going to be over that hamate bone. It's going to be on the palmar aspect. You can either have it on the hook of the hamate or the body of the hamate, depending on which part of the hamate bone was fractured. So that's our history, observation, palpation. For joint testing, you're not going to do much joint glides or anything like that, since with the distal fracture, you don't want to do any range of motion or joint play based on an obvious displacement. And then for the scaphoid and the hamate fracture, in joint glides and joint play, you're not going to find anything positive. For the range of motion testing, again, the distal forearm fractures, it's contraindicated. You do not perform active or passive or resistive range of motion. But with the scaphoid fracture, we can do active range of motion for the wrist and the fingers. So for this, they will have pain during active wrist extension. So if I can have you put your wrist towards the ground. At the end range of motion, they'll start to feel pain localized at that scaphoid bone. And then you can have them do some ulnar deviation. So that's putting their hand towards their body. And there's going to be some pain with that because this compresses the scaphoid bone, puts pressure on it. So those are the positives for active range of motion for the scaphoid that are going to be positive. For the passive range of motion for the scaphoid, there's going to be some pain when I passively do wrist extension, when I passively do the ulnar deviation, and then there may be some pain at the end range of motion of wrist flexion. And then manual muscle testing, we may experience some weakness in the thumb manual muscle testings. So if I do put them in this position and I ask them to abduct their thumb against pressure, they may have some pain with that. If I ask them to do some adduction, there's be some pain there. And then you can test the MCP flexion, so trying to bring your thumb towards your hand. There's be some pain there. And then some active opposition, so touching your thumb to every finger. They may have pain for the scaphoid fracture, as this is one of the main movers during that movement. For the hamate fracture, the active range of motion, so they may have some pain during adduction and abduction of the fourth and fifth fingers. So if I ask them to spread their fingers out, they may feel some localized pain at that hamate, and when I ask them to bring them back in, they may feel some pain on that as well. Passively, you're going to notice this with some wrist extension. There's going to be some pain at the hamate, and then also during the fourth and fifth fingers, if I passively extend them, they may get some pain there as well. Passively flex them, could compress it, and they feel some pain on the hamate as well. The manual muscle testing, you don't really do much for this. It's kind of in that active range of motion that you'll notice their pain. So we've done the history, observation, palpations, and then we will go into our active range of motion, and finally is special testing. So for the distal forearm fracture, there are no special tests. You may use a tuning fork if it's not an obvious deformity. You could use the tuning fork over the styloid process of the radius or the ulna to see if that produces pain. For the scaphoid fracture, again, you'll want to use that tuning fork, place it over the anatomical snuff box, and you can also try on the palmar aspect over the scaphoid, see if they get any pain with the tuning fork. Another special test that we could try is the carpal compression test. So for this, I'm going to have her place her hand so you can see. I would begin palpating on the first metacarpal. As you palpate down and you're adding compression, when you get over that area of the scaphoid that is fractured, if you're adding that compression, they may get a positive for some pain there. So you'll want to ask for their feedback as you're palpating down on the compression test. Another test for fracture that may be positive is the long bone compression test. If you apply an axial load down the thumb, that may cause some pain in the scaphoid as the axial load is getting pushed onto the scaphoid. Not always going to be a positive, but there's a chance that that could be positive. For the hamate fracture, the special testing is again very limited. You can do the carpal compression. It's not really a formalized test, but if you do your carpal compression starting at that metacarpal on the 5th, you can palpate down adding compression, and as you get over that hamate, they may feel some pain when you compress over the hook of the hamate. And then also the long bone compression, so you can use the 4th and 5th fingers, apply that up the joint, and then they may feel some pain on the hamate. So that is the extensive history, observation, palpation, range of motion, special testing for fractures of the upper extremity. You have the distal forearm fracture, which is going to be an obvious displacement. There's not much outside of the history and observation that we're going to be doing as clinicians to evaluate that if it's obvious. For the scaphoid fracture, your key findings are going to be in your history, making sure that you identify the mechanism of injury. It's going to be a Fuchs mechanism or a direct blow to the scaphoid, and you'll want to be careful with the avascular necrosis. It has a poor blood supply, so anything where they have localized pain in that anatomical snuff box, you'll want to be considering the scaphoid fracture as a high possibility. And then in your range of motion, you may find that during extension and ulnar deviation, they have some pain actively. That would indicate some scaphoid involvement. For the hamate fracture, the key findings, they may have some neurological symptoms if the ulnar nerve is involved. So in the 4th, 5th, and middle finger, they may get some numbness or tingling. That's a key sign. Another key sign is if the mechanism of injury, if they were holding sport equipment like a bat or a lacrosse stick during the incident and they had the Fuchs mechanism, that is a very high possibility that the hook of the hamate was fractured off. And then the special testing, you're not going to be able to do very much, so you want to rely on your history and inspection and palpations to give you those key findings of the localized pain. The hand is such an intricate place. You're going to really want to make sure during your palpations you're being thorough on where you're palpating and asking them exactly where they feel that pain, and that'll give you the indication on which carpal bone may be fractured. Hopefully this video is helpful in determining some fractures of the forearm and hand, and that is the end of this video.